Hello, I'm Professor Mike Lewis. I am the Emeritus Professor of Oral Medicine at Cardiff University. I've been a Professor of Oral Medicine here for about 20 years. As well as my role here in the university, I was the President of the British Society of Oral Medicine and the President of the British Society of Oral and Dental Research. What is dry mouth? Well, it's a very subjective question. Dry mouth is a reduction in the production of saliva. Now, we're all producing a certain amount of saliva throughout the day. At rest, most of the saliva is coming from the submandibular glands, but at periods of time where we need more saliva, the parotid glands kick in and produce more saliva to aid taste, swallowing, and eating. Now, in certain situations in patients, if there isn't sufficient reserve for saliva, then the patient will have difficulty and complain, there's not enough saliva for me. And that can be very variable between individual patients. You can have a small reduction in production, or in some patients, a total absence of saliva. The causes of saliva are mainly 5. And when I have students here on the clinic with me, I've got some students around me, and there's usually 4 or 5 on them, and I'll say, right, give me a cause of reduced salivary production or dry mouth. And very often the student will first chip in with the most common cause, which is actually related to drugs. Most patients who have a dry mouth are caused by the medical profession because certain medicines will reduce salivary production. So the first main cause is drug related. Then the students will say, what's another one? The next one is probably connective tissue disease. And this is related to Sjögren's syndrome. And Sjögren's syndrome is an autoimmune disease that's quite common, and it's characterized by dry mouth. Now, Dr. Sjögren was an ophthalmologist, and he found patients with dry eyes and dry mouth and found out that it was due to destruction of the salivary glands and destruction of the lacrimal glands. Another cause of dry mouth is a side effect, again, of medicine and surgery, radiotherapy. If anyone is unlucky enough to have radiotherapy to the head and neck for a tumor in the oropharynx, unfortunately, the radio waves will pass through the salivary tissues. They don't destroy the salivary tissues, which is sometimes what people think. They actually desensitize the salivary tissue to the neural input. So the patient post-radiotherapy will suffer from a dry mouth. One the students always forget is diabetes. They may say dehydration. Well, I say, well, how does somebody become dehydrated? When maturity onset diabetes, which is increasing dramatically in the world, is characterized by raised blood sugar and then increased urinary output. So what happens is, if the diabetes is not diagnosed or poorly controlled, then the patient will complain of a dry mouth due to increased urinary production. There is a very rare cause of dry mouth, which is to be born without your salivary glands. But in 40 years of working in oral medicine, I have only once seen a patient with absent salivary glands. In addition to the 5 recognized causes of dry mouth, patients often come in and complain, I get the dry mouth at night. Now, there are 2 reasons for that. One is that when you go to sleep, your salivary glands go to sleep. So that background salivary production drops off, which is going to give the sensation of a dry mouth. But also, if you can't breathe through your nose properly, you breathe through your mouth. And if there's obstruction within the nose, or if you may relate, if you've got a cold and you're asleep, you breathe through your mouth. And of course, with the mouth being open, it dries up. And patients will say, I just get my dry mouth at night. For some patients, it's necessary to get ENT to have a look, just to look in the nasal passages and see if there is a passage there for the air to breathe, so the patient can then return to sleeping with their mouth closed. Well, what sort of patients suffer from dry mouth? Interestingly, it's incredibly rare in children. It's usually adults and increasingly older adults. Now, mistakenly, some people think that dry mouth is a part of growing older. It isn't. What the problem is that the older patients are more likely to be taking some of the drugs that have a side effect of causing a dry mouth. So it's the drug-related condition, which is the most frequent. And the other patients are, as I say, the undiagnosed diabetic patients. So if somebody comes in with a dry mouth, you would always want to do their blood test for the HbA1c, which would give a good monitor of the patient's diabetic status and the potential for them to have undiagnosed diabetes. And the group of patients who understandably would know if they've had radiotherapy to the head and neck, they'll be able to tell you that, of course. And so it's been part of their treatment for perhaps oropharyngeal carcinoma. What will we do for somebody with a dry mouth? Well, there's a logical progression we would go through. Firstly, you might say, well, if they haven't got saliva, can we provide it? And there are a number of artificial saliva substitutes available. And some have pros and cons in relation to, some are based on animal products, and some may have a low pH in their delivery. But there's a range of what we call artificial spit, artificial saliva. One of the problems with them is, though, the effect is fairly short-lived, and many patients resort to just frequent sips of water. So that's the artificial saliva. Now, can we in some way get the salivary glands that are there working? So can we stimulate salivary flow? And of course the answer to that is yes. And so you can use certain things as sugar-free chewing gum, and where you're chewing, and that sends a message to the salivary nucleus in the brain, which then sends neural messages to the salivary glands, make saliva, I'm chewing. So that is quite helpful, but obviously they have to be sugar-free. Our diabetic sweets, one of the things to avoid, but I occasionally see it there, are glycerine and lemon products. The glycerine is there to hold a lemon, which is acidic, which stimulates salivary flow. However, this lemon juice is acidic and should be avoided in people with teeth because it's going to promote dental caries. So you have the salivary substitutes, these salivary stimulants. There is one systemic salivary stimulant called pilocarpine, which is a drug which the patient will swallow about half an hour before eating, and that will stimulate salivary glands. It will stimulate lacrimal glands if they have dry eyes as well. The problem is it also stimulates sweat glands, and patients do not tolerate that side effect. And there are some interactions. So pilocarpine, whilst it is a potential, it's rarely a practical solution. Then we're into the world of prevention, because we've now got to counteract the impact of not having enough saliva. So the first thing is obviously an effective toothbrush. The effective toothbrush the patient can use. If they have reduced manual dexterity, so some patients with Sjogren's syndrome will have rheumatoid arthritis in their hands, and it's very difficult for them to hold a regular toothbrush. So some of the electric type or oscillating toothbrushes are very helpful. Also, with the toothbrush, you can interdental cleaning, such as I call them the Tepe brushes that can help clean in between the teeth. So you've got the toothbrush, interdental cleaning. You would need an effective toothpaste, and obviously effective toothpaste containing fluoride. And there are some patients would prefer to use toothpaste that don't contain sodium lauryl sulfate, the SLS. That's the foaming agent in toothpaste. Some of them don't like that. So there are some SLS-free toothpaste around. Then you will come to mouth rinses. And the patients should really get into a daily routine of using a mouth rinse containing fluoride, and also providing, such as this one here, which is providing fluoride, but also providing hydration to the mouth. So you've got the daily rinsing methods as well.